Many think endometriosis is confined to the uterus and the ovaries, but that's just simply not the case. Endometriosis can affect other areas like the bowel, bladder, diaphragm, and in rare cases, even the lungs or brain. Have you been told to become pregnant to cure your endometriosis? Have you been handed birth control and told this is all you need? Have you been told that surgery will cure your endo or that you can't have endometriosis because you're not in pain? These are among the most common misconceptions about endometriosis, and we're breaking them down in today's video and bringing you the truth. Welcome back to the Endo and Fertility Space channel. If you or someone you know struggles with endometriosis, I'm shedding light on the most common misconceptions about this condition and, most importantly, debunking these myths using research-backed facts in today's video. As always, please give this video a thumbs up, share it with a friend, and subscribe to my channel if you haven't already. So the first common misconception that I want to talk about is that endometriosis is just a bad period. This is one of the most common myths about endometriosis. While it's true that severe menstrual pain can be a symptom, endometriosis is much more than that. It's a chronic inflammatory condition of immune dysfunction with hormone and nervous system involvement. The lesions that grow with endometriosis have been found on every organ of the body and can be so severe and so deep infiltrating that they can cause bowel obstruction or puncture, bladder infections, and even lung collapse. Fatigue, insomnia, and depression are common reported symptoms of endometriosis, as are pain with intercourse, pain with urination, and pain with passing stools. Nausea and pain that is so severe it interferes with work, school, and social life are also commonly reported symptoms in endometriosis patients. UTI-like symptoms, bladder pain, pressure, and urgency are also common. Infertility affects up to 50% of women with endometriosis, and up to 30% of people without an endometriosis diagnosis are suspected to have endometriosis as a root cause. There have also been case study reports on silent loss of kidney function and endometriosis in the brain. The second common misconception is that endometriosis only affects the reproductive organs. Many think endometriosis is confined to the uterus and the ovaries, but that's just simply not the case. Endometriosis can affect other areas like the bowel, bladder, diaphragm, and in rare cases, even the lungs or brain. Various case studies show rare locations of endometriosis, including this review showing endometriosis of the L5 nerve and gluteal muscle. This case study shows a 40-year-old woman with left liver lobe endometriosis, and the previous case study I linked showed endometriosis found in the brain. So the next common misconception is that pregnancy cures endometriosis. Research strongly disputes this misconception that pregnancy is a cure for endometriosis. Studies show that while some women may experience temporary symptom relief during pregnancy due to favorable hormonal changes, this experience is not shared by all women with endo, and symptoms often return postpartum. Furthermore, endometriosis is a chronic condition influenced by multiple factors, and pregnancy does not stop its progression or eliminate underlying lesions or factors at play in the progression of the disease. Another reason why this is not only a misconception, but also an insensitive recommendation is that endometriosis is associated with increased risks of pregnancy complications, including recurrent pregnancy loss and difficulty becoming pregnant to begin with. Okay, the next common misconception is that hormonal birth control cures endometriosis. There is no disputing that hormone therapies can help manage symptoms of endometriosis. However, they do not eliminate existing lesions or cure the disease. It is true that because endometriosis lesions increase estrogen expression and suppress progesterone receptor binding to sustain growth of these endometriosis lesions, that targeting estrogen can be a fruitful strategy for reducing symptoms and inflammation. Many studies and reviews like this one show that hormone therapies can be helpful for symptom management. One downside is obviously the inconsistency with fertility objectives. This study showed that hormone therapies postoperatively can extend the interval between repeat surgeries. However, and interestingly, the location of the endometriosis, presence of endometriomas over 20 millimeters, and elevations in the inflammatory marker CA125 were associated with faster reoccurrence, whether or not the individual was taking birth control post-operatively. Lastly, this systemic review showed that many women experience symptom recurrence after stopping birth control, which shows the non-curative nature of birth control and hormone therapies. Specifically, 17 to 34% across 58 articles reported a recurrence of pain when stopping hormone therapy. So can hormone therapies help with calming symptoms and possibly extend the length of time between surgeries? Yes. Can it cure endo or stop progression? No. Okay, the next common misconception is that endometriosis always causes infertility. Studies have shown that approximately 30 to 50% of women diagnosed with endometriosis experience infertility. Additionally, endometriosis is found in about 25 to 40% of women who are infertile. Women with endometriosis also have an estimated 2 to 4 times increased risk of infertility compared to the general population. The likelihood of conception varies with the severity of endometriosis also, so this is an important consideration. About 75% of women with mild endometriosis conceive within 1 year of trying. Approximately 50% of women achieve pregnancy within a year that have a slightly more advanced stage of endometriosis, and around 25% become pregnant within the same time frame who have severe or deep infiltrating endometriosis. Bottom line, it can be more challenging to conceive, but it's not always impossible. There are many things within your control to improve your chances of conceiving with endo, no matter what stage of endometriosis you have. Check out my video on 8 steps to getting pregnant with endometriosis. I'll link it in the show notes below. We also know that conception and fertility rates do increase post-excision surgery, so this is another thing to keep in mind. Okay, the next common misconception is that endometriosis is easy to diagnose. While decades have gone by with little to no research in women's health and endometriosis, we are seeing more and more research around shortening diagnostic timeframes for women with endometriosis. As of right now, laparoscopy with biopsy of suspected lesions, I would argue, is the most accurate way to diagnose endometriosis, but realistically, it is an invasive way to get a diagnosis that is not accessible to everyone and that has a long recovery time for many people who pursue the surgery. Let's summarize some of the new innovations in this field. This is a summary of the research underway, not a presentation of existing accurate and reliable ways of getting a diagnosis. So firstly, 2 University of Adelaide research institutes, the Robinson Research Institute and the Australian Institute for Machine Learning, are harnessing the emergent power of artificial intelligence to revolutionize endometriosis diagnosis. This technology combines ultrasound, magnetic resonance imaging, or MRI, and artificial intelligence to make image endo a cost-effective, accessible, and accurate way to diagnose the condition without surgery. Researchers at the University of Oxford are investigating the use of a radio-labeled tracer in conjunction with SPECT-CT imaging to detect superficial peritoneal endometriosis. This novel imaging agent binds to the cell adhesion protein AV beta 3 integrin associated with new blood vessel formation in endometriotic lesions. Preliminary findings suggest that this method could serve as a non-invasive tool for detecting early stage endometriosis, but research is still ongoing. A collaborative study by the Royal Women's Hospital and Proteomics International has shown promising results for a blood test. Researchers analyzed samples from over 800 participants. Preliminary studies have shown that it could be helpful for cutting diagnostic times and reducing the need for surgical diagnosis of endometriosis. Other studies show that transvaginal ultrasound has proven to be a reliable tool for detecting deep infiltrating endometriosis. A systematic review and meta-analysis reported that transvaginal ultrasound has a specificity up to 100% in diagnosing deep infiltrating endometriosis. In scientific study language, this means that transvaginal ultrasound was able to accurately rule out people without deep infiltrating endometriosis with 100% accuracy, or did not produce any false negative results. Another study demonstrated that transvaginal ultrasound could accurately diagnose deep infiltrating endo involving the uteral sacral ligaments, torus uterinalis, and posterior vaginal fornix with a specificity of 87%. So none of these tools, with the exception of advanced ultrasound, are in use at the moment, but this is really exciting research to keep our eyes peeled for. The next common misconception is that endometriosis ends after menopause. While symptoms may improve after menopause due to decreased estrogen levels and no longer having periods, endometriosis doesn't disappear. Some people continue to experience symptoms or require treatment. While research to date in postmenopausal women with endometriosis is limited, one thing we do know is that endometriosis lesions change over time and into menopause. We know that as endometriosis lesions age, they become white and fibrotic. So while they may not present as red, blue, or black early lesions with a fresh blood supply, they can continue to cause problems and symptoms more aligned with this type of lesion. Symptoms that may change in menopause include symptoms more consistent with organs being bound and less mobile, changes in bowels, persistent pain, discomfort in one area, digestive symptoms, pelvic floor dysfunction, or pain with urination and or defecation. Okay, the next common misconception is that surgery cures endometriosis. Surgery, like excision surgery, can remove lesions and improve symptoms. I mean, that's kind of why we pursue excision surgery, but it's not a permanent cure, unfortunately. Endometriosis can reoccur, and many patients require ongoing care. As we've already discussed in today's video, hormone therapies can lengthen the time to recurrence, but even with conventional medical management, endometriosis is still known to reoccur. One meta-analysis showed recurrence occurred in 27% of people 24 months post-excision without medical intervention, while another study reported recurrence rates of 2.2% per year up to 22.5% 8 years post-op. The difference being attributed to the use of post-operative hormone therapy. All right, and the last common misconception that we're going to talk about in today's video is that endometriosis pain is always severe. While many people with endometriosis experience severe pain symptoms, the level of pain doesn't always correlate with the extent of the disease. Some with advanced endometriosis may have little or no pain, while others with minimal lesions can experience debilitating symptoms. An estimated 20 to 25% of endometriosis patients are estimated to live with silent endometriosis. I recently did a video on silent endometriosis, some signs to look out for and how to manage, so I will link that in the show notes below. Thank you so much for tuning into today's video. I hope you learned something new. If you haven't already, please give this video a like, share it with a friend, and hit that subscribe button, and I will see you in the next video.